Welcome to tonight's Goodfellow webinar on depression and distress in primary care. My name is Dr. Courtney White, and tonight we'll hear from two speakers, Professor Pim Cuijpers, the Professor of Clinical Psychology in Amsterdam. His work is focused on prevention of mental health disorders. We also have Professor Arroll, General Practitioner and Director here at the Goodfellow Unit. So I will now hand over to Pim. Thank you, Pim.
Thanks, Courtney. First of all, thank you for the introduction, and I'm impressed that you managed to speak my name in the correct way, because that is almost impossible for people not in Holland. But that aside, yes, I'm Pim Cuijpers. I'm a professor of clinical psychology. I've worked in mental health care for many years before I became a professor. And I've been working in the treatment and prevention of depression for the last 25 years. And what I want to do is I want to give a brief introduction about what we know about treatments of depression in general and in primary care. And I will be using a lot of our research on meta-analysis, in which we try to integrate the results of multiple randomized trials into one best estimate of the outcomes. I'm a psychologist, so I start with psychological treatments. But I will also talk about how they compare with pharmacological treatments and with combined treatments. If you want to know more about depression, where it comes from, causes, epidemiology, and treatments, you should read Lancet Psychiatry, or the paper in the Lancet on depression, which we published last year. It was a joint commission of the Lancet and the World Psychiatric Association, and it has everything you want to know about depression. So these are all psychological treatments which have been found to be effective, and you probably don't know them all. You may have heard of cognitive behavioral therapy, and not all of them are used in primary care. And in the next slide, I will explain a few which are used in primary care. But here you see the ones who are tested in at least 10 randomized trials. And you see the number of trials in the second column called K, and the numbers needed to be treated in the next column, which ranges from 3 to 8. I also give the effect size after that, which, because depression is, it's not really a binary thing. It's not that you have it or you don't have it. It's more something that you should understand as a continuum. Some people have nothing, some people have it very severely, but most people are somewhere in between. And when you have a variable like that, it's better to look at treatments compared to control groups in terms of standard deviations of the difference, which is complicated. I understand that. And it's very difficult to explain what it means, but it is a good indication of the size of the effects. But it's easier to understand just the numbers needed to be treated. How many people do you have to treat in order to have one more positive outcome compared to usual care? And so these are all the therapies which have been examined in a lot of trials. And the issue with these therapies is that they all work, and you see different effect sizes and NNTs. But when you look at the significance of the difference, there is none. So they are all better than usual care or other control groups. And there is no significant difference between them. So they all work. It's just like SSRIs, where we also have all these different SSRIs, and they don't really have big differences between them. Same is true for psychotherapies. They all work as long as they're manualized, and that doesn't mean you can do anything, but they all work just as well, so to say. So which ones are used a lot in primary care? First of all, behavioral activation. That's a behavioral therapy. Bruce has done research on that, in which you, simply said, try to stimulate people to do fun things, because people who are depressed don't have positive things in their lives anymore. So you try to structure how they fill in their days and try to fit in pleasant activities. Very simply said, of course, it's much more complicated, but that's the basic idea of this therapy. Then we have problem-solving therapy that's also used a lot in primary care, and there are short versions of it specifically tested in primary care, because that can also be used by nurses, for example. There's quite some research in which nurses applied problem-solving therapy successfully. In problem-solving therapy, you select the most important problems you have in your life. You pick the most important one. You generate all kinds of solutions. You choose the best solution you see for this problem. Make a plan to do it. You actually do it, and if it works, then the problem is solved. If it doesn't work, you go back to the first step and see which other solution you can find to solve it. So it's very rational, very simple and straightforward in a way, but for many people it works quite well.
And probably what GPs do in their everyday life.
I think so.
Yeah, it's sort of like a standard.
So. Yeah,
it's what we sort of naturally do.
Yeah, that makes sense. Yeah. And then we have interpersonal counseling, in which it's a brief version of a more extended interpersonal psychotherapy, in which you focus on interpersonal issues. For example, problems at work with your boss, of other colleagues, or within your family, or you have lost somebody by death. And then it's a more counseling way of dealing with these losses and these social problems. And then we have CBT. CBT is by far the best type of psychological treatment. It's not better doesn't work better than other therapies, but it is examined in many more trials than any other kind of therapy. And the basic idea is that people who are depressed are very much inclined to think negatively about themselves, about their lives, about their futures. And what you do in CBT is you try to identify what thoughts people have. What thoughts do they have when something happens? Like, I'm a total failure. When something doesn't work, oh, this always happens to me. Why exactly me again? And so what you learn in CBT is to learn what thoughts, negative thoughts you have, and how you can discuss them with yourself, that you recognize them and you discuss them with yourself so that you start thinking more positively. So these are the types of therapy which are used a lot in primary care research, and they all have found to be effective in primary care. And so what is also important to understand about therapies in general is that it doesn't matter so much how they are delivered. That can be individual, that can be in groups, that can be by telephone. It can also be through guided self-help, which usually nowadays goes through the internet, where you explain how a psychological treatment works, and that the patient starts applying that psychological treatment to herself or himself. And then there is a coach, but that coach only spends 10 or 15 minutes per week to look at the homework assignments that the patient does, to answer questions, to see whether the patient is on the right track or not. And then we have, so it doesn't matter how you apply these therapies. It can be individual, group, telephone, guided self-help, through the internet, digitally, or otherwise. If there's no human support, so unguided self-help, you have these websites where you can go to and you just have this psychological therapy and you can work through it on your own without any help. They don't really work very well. In other studies, we've shown that they have a little effect, but much smaller than when there is human involvement. So, as I said, effect sizes are very difficult to understand. Numbers needed to be treated also have the problem that there are relative outcomes, meaning that you have an NNT indicating the effect of an intervention compared to doing nothing, or compared to placebo, or compared to another treatment. And what we did in one study is we just looked at the actual response and remission rates. And response indicates the reduction of symptoms with 50% compared to baseline. So when people have improved 50% of the symptoms, remission means that people are completely better again, so they're normal functioning. And here I also give the rates of deterioration, because there are always patients who get worse during the treatment. Usually it's very difficult to examine that, but because we have all these meta-analytic data, we can look at these proportions.
So in terms of the 0.4, that means 41% of people get a response.
Exactly.
And within that, the 26% get a remission. So
that's exactly,
and
what
5% get worse. So
yes.
It's not spectacular, is it?
No, but if you look at usual care, then the response rate is 0.17. So the actual benefit is 24%, 1 in 4, which could be an overestimation, but it's probably something like that. This is, I will come back to that later. This is the same what you find for antidepressants. So a lot of people get better from antidepressants, but it's not that everybody responds to that, and certainly not remits. That's actually only a minority of patients, both for psychological and for pharmacological treatments. It's still better to get a treatment like that, because it's much better than the response and remission rates in usual care. So I still would recommend people to do this. So if you treat people with psychological treatments for depression, you see that depression goes down, but it also has an effect on all kinds of secondary outcomes, which are smaller than the effects on depression, but still significant. And that's true for quality of life, social functioning, social support goes up, self-esteem goes up, anxiety goes down, people feel less hopeless. They, as I said, for CBT, that dysfunctional thinking is really a big problem that also improves. And there is a small group of studies in mothers who are depressed. And what we see is that if you treat mothers with depression, that also the mental health in their children improves significantly. The interaction between mother and child gets better, and parental functioning in general also improves. So treatment of depression with psychological treatments has also a lot of secondary benefits. And there are a few other things. There's a lot more to say, but I don't want to talk too much. There are a few other things I want to say. Age doesn't matter. So as long as people are adults, therapies work. That's also true for older people, including older old people above 75 years of age. So it works regardless of age. It works also when people have comorbid general medical disorder, cancer, heart disease, diabetes. The effects are comparable in perinatal depression. We do not find that longer therapies have larger effects. We do find that the effects are smaller in children and adolescents, in people with subthreshold depression, although we see in that group that psychological treatments can prevent the onset of major depression. Possibly the effects are smaller when people have chronic depression, and it's definitely smaller when people also have comorbid substance use problems. And we're now, while I'm here in New Zealand with Bruce, we're working on a new meta-analysis in which we compare psychological treatments in primary care with specialized mental health care. And we may find that the effects are smaller in primary care. Not so much the response rates, but the proportion of people responding in the usual care groups, which would indicate that people, that the spontaneous or natural recovery rates are higher in primary care than in specialized care, which makes sense in a way. So how does this compare with pharmacotherapy and combined treatment? Well, briefly said, psychotherapy and pharmacotherapy at the short term have comparable effects. So in the acute phase treatments, there's not a significant difference between psychotherapy or pharmacotherapy, but combined treatment is definitely more effective than either psychotherapy alone or pharmacotherapy alone. And we examined that for remission, but also for response and the effect sizes I showed earlier. What we did find is that the dropout rates, it's a rough indication of we looked at study dropouts, so that may not be treatment dropouts, but that was larger in pharmacotherapy alone. So if you give people psychological treatment and the pharmacotherapy, they're more inclined to stick with treatments than pharmacotherapy alone. We looked at all these specific types like chronic and treatment-resistant depression, and the findings were very comparable. Also for when we selected only the studies with severe depression and also the long-term outcomes. Well, this is a bit of a more complicated slide, but I do want to show it to you very briefly because I'm getting out of time. My colleague Toshi Furukawa led one large meta-analysis in which we looked at long-term outcomes. So people get an acute phase treatment and a maintenance treatment. The total time was a year on average. And so in the acute phase, they could get psychotherapy or pharmacotherapy or combined treatments. And then in the second phase, they could switch to any of these. So they could switch from combined treatment to psychotherapy alone, from combined treatment to pharmacotherapy, from pharmacotherapy to combined, et cetera, et cetera. And basically what you see here is the odds ratio of a better outcome. Also, again, response rates. And COM indicates combined treatments. Natural is just care as usual, so to say, the natural trajectory. Psi is psychotherapy, Pha is pharmacotherapy. And what you see here is simply said, it says that at the longer term, combined treatment is definitely the most effective. Psychotherapy only once or continued during the maintenance phase is better than pharmacotherapy. Pill placebo is really worse than treatment with pharmacotherapy. So yeah, this is an important thing. This is also, I think more and more people are considering not to recommend pharmacotherapy as a first-line treatment and start with psychotherapy. And then if that doesn't work, add the combined treatment to that. I'm in the treatment guideline committee of the WHO, the MHGAP, and that's what we're probably are going to recommend there. So my conclusions, there are all kinds of psychological therapies available. They have comparable effects. There's not one therapy better than another one. There are several ones which have been specifically developed for primary care: behavioral activation, problem solving, interpersonal counseling, CBT. The effects are important, but also modest. So a lot of people do not respond to any treatment. They have comparable short-term effects as pharmacotherapy, but combined treatment and also psychological treatments are at a longer term better. And as I said in the WHO guidelines, we are going to recommend not to use antidepressants alone. Okay, that was my introduction.
Okay. So my session here, I'm going to present 5 cases from my clinic, and Pim will give a commentary on that. So I've titled my part of the talk, Depression, Distress and Primary Care. And I just wanted to make the point about the issue of labeling depression in primary care. I mean, GPs aren't particularly trained to diagnose depression like psychiatrists are, but I'm a great fan of using these questionnaires like the PHQ-9 and the G87 because it gives you a mark in the sand. And you can see if people are getting better or not. In fact, we're going to show a case tonight of someone who's not getting better. And what do we do? What are your thoughts on depression, distress, when we come to primary care?
Yeah, I think that makes complete sense not to separate them too much, because it also doesn't matter for the treatment you give. So if you take, for example, antidepressants, they work for both depression and anxiety disorders. Most psychological treatments we're also moving more and more to what we call transdiagnostic treatments, which work in depression, anxiety, high stress levels. And so I think it's only when people don't get better and they are referred to specialized mental health care that a better labeling may help better treatment. But I think it makes completely sense not to go into more depth.
And those of you who are aware that I'm interested in focused acceptance and commitment therapy, we avoid diagnostic labels. We tend to say patients are stuck. I often say they're distressed with reduced motivation or distressed with excessive worrying. For WIN certificates, I now use the term adjustment reaction because it's a read code and it will get people their payments without labeling them with a big label. Because as I say when I do the teaching on this, if you get a diagnosis of major depression disorder when you're 21, it'll still be in your medical chart when you're 101. So nobody will take that out and it will affect your insurance and a whole lot of things. So, okay, so case 1 is a woman in her early 50s. She's European. She's not been feeling good for a few months. She has an EMA-QOL score of 40, which I'll explain, a PHQ-9 of 16 out of 27, and a GAD of 8 out of 21. A PHQ greater than 10 is associated with a so-called significant level of depression. A GAD 8 or greater is associated with a significant level of worrying. Notice I avoid the word anxiety, although we will talk about depression and anxiety. The EMA-QOL is a scoring system that I invented. It was a gem a while ago. What is your emotional quality of life now? If 100's perfect and 0's worst imaginable, what's your score? Her score was 40, so you know she's got some low mood. Her PHQ-9 will be greater than 10. You need to be greater than 60 to have to not have a low mood. So, so what is your emotional quality of life if 100's perfect and 0's worst imaginable? Her issue, which came out on my Work Love Play form, was staff weren't being replaced at work when they left, and that made her feel like her job wasn't valued. So I used a thing called Work Love Play. It's on the website tonight, hopefully. I'll need to check that. We might put it into the chat as a link. It's on my website, brucearroll.com. And that's what we call a contextual history. So she gave how she was doing at work is 3 out of 10. So that's a bit of a flag. You need to check that out. She gave 8 out of 10 as in friends, although it turned out she hadn't been in touch with her friends recently. 0 out of 10 for current partner. Previous partner or husband had a drinking problem. Lovers and family was 8 out of 10. And play recreation was 3 out of 10. So again, and that's almost predictable. You know, people will stop getting in touch with their friends and stop playing and doing recreation and stopping exercise. The 3 classic things pretty well everyone I see who's distressed. This is the Then you ask people these questions. What have you done? What about current exercise? And she mentioned she'd done a half marathon. Her sleep was poor, no drugs or alcohol, gambling not an issue for her or family, violence with her previous husband. He'd got verbally aggressive when drunk. She didn't have a spiritual aspect of her life. The club she belonged to was Al-Anon, which is for family members of people with drinking problems or drug problems. And in terms of the question, do you have any traumas that are unresolved? Remember, we all have traumas in our lives, but we resolve most of them. And what you're interested in is unresolved trauma, because that can really change the direction of your consultation, particularly if there's childhood abuse. And she had issues with her husband, but she was okay now. So we talked about behavioural activation, and those of you who know my work know that I'm very keen on behavioural activation, because it's probably one of the most effective treatments for, a bit hard to tell, but it's certainly got the best numbers needed to treat behavioural activation. And sadly, I only learned this about 4 years ago from Pim when he sent me a paper, and I was horrified to realise this jewel had been available. It's so easy to do. So we got her to contact a friend for a movie, and she gave the likelihood of doing that as 8 out of 10. Remember, they've got to get more than 7 out of 10. Otherwise, they're probably not going to do it. If she says, I'll contact a friend and go to a movie, 2 out of 10, her subconscious is telling you, this isn't going to happen. You might as well give up and renegotiate. Is she willing to exercise 3 times a week, 9 out of 10? Her pain, her psychological pain wasn't being valued. So I did a thing called holding lightly and breathing slowly. So basically I get my patients to hold the feeling not being valued lightly and breathe slowly. And this is a form of exposure therapy to that painful thought. And when people breathe slowly, their heart rate variability comes back into a good range, a healthier range with good variability. It's like a fetal heart monitor. You get good beat-to-beat variability. And they feel better within a couple of minutes. And you say, how are you feeling? Oh, that's interesting. Holding it lightly works. We look at self-kindness and ask her to let it go, and then what's possible. So when I saw her at the next visit, she was completely back to normal. She'd done all her tasks. Her PHQ-9 and GAD-7 were both 4, and her EMA-QOL was 80. She did say that the holding it lightly had been quite useful when she had some uncomfortable feelings. So that was, and we did a randomized trial in my clinic. 46% of people were better in 1 week. So what behavioral activation, should we be doing it?
Well, this is an excellent case, of course, because she really did what she had to do. Mm-hmm. Many people don't do that. Yeah. But she clearly did what she had to do, and that worked out well. So that's really very good. I would, the next time you see her, I would check whether everything is going okay. Because if I look at the causes, it's probably the work thing that made her bad, so to say. And so, but everybody has work issues at some point in their life. Yeah. And why was it that this stressed her so much? And so that could be something, there could be something else going on with her husband, or earlier trauma, which she didn't remember or whatever. So I would check on her the next time you see her.
I didn't see her for a couple of years later, basically. And that's one of the important points, actually. You need to do something at the first visit, because half the patients don't come back again. Fortunately, she came back. Yeah. And if you refer them out, half of them don't get to wherever you go. That's why the health improvement practitioners are such a good idea in Auckland or in New Zealand. I'm going to talk the 5 cases I've got tonight. 4 of them were successful, 1 wasn't. And the reason I chose the ones that were successful is I think you actually can then figure out what you did that worked. With the case who didn't get better, we don't really know why she didn't, and she's the next one. So this is just a comment about the work-love play. So it gives a snapshot of people's life. Takes less than 5 minutes, and it gives you all the avoidances and escapes, which is what people do when they get distressed. They start avoiding things, seeing people doing things, and they escape with drugs and alcohol. So again, you've got to ask about drugs and alcohol with these people because it's just such a natural thing. They're readily available and people feel better when they use them. I say they fly now and pay later. So they feel better immediately, but then they don't sleep very well. Their mood will go down. And I think it's very hard to get people better if they've got substance issues. I think your work shows that, doesn't it?
Yeah, very clearly.
Yeah. So Freud came up with the idea of work love, and then Patty Robinson of Fact Fame came up with work love play, and I've expanded to work lovers and friends, lovers and intimates, lovers and family, and play. And even lovers and family can get a bit complicated. I get on with my grandmother, not my sister, and I love my little brother, sort of thing. And they score the first top 5 things 1 to 10, and we've done some analysis on that, 10 being good, 1 being terrible. And these are the social questions: drugs, alcohol, violence, trauma, smoking, sleep, exercise, smoking, not because smoking affects mental health, but it can be an escape behavior. And of course, we need to ask about smoking. And with smokers, we need to ask at every visit in order to get them to stop. Ask about their values, what's important to them in the long run. You can ask their cultural identity if you want, if you're not sure. That's quite a nice way if you're not sure what their cultural identity is. That can be helpful. And the avoidances and escapes are clear and obvious, and these need reversal. So our job is to reverse those ones. And for half the population, they'll be better in a week. We've got pretty good data on that now. And that's been, these rapid improvements have been shown for behavioral activation.
Can I say something about smoking?
Yep.
There is a clear association between people smoking and depression.
Right.
So the number of people who smoke, the prevalence of depression is much higher. At some point, we thought that when numbers of people smoking go down, it will only be the ones who are depressed who will remain smoking, because it's also much harder for them to stop smoking. There's a lot of research on that. And there's also trials in which you learn them stop smoking skills. And when you combine that with behavioral activation, that it's easier for them to stop smoking.
Okay.
Yeah.
Okay. So yeah.
Smoking is really related to mental health problems very much.
Right. So remember, this is the pattern. Lovers and friends, people stop contacting their friends. And of course, when you stop contacting your friends, they think they've done something to upset you, so they don't contact you. So you get this Mexican standoff. Play and pleasure go down and exercise goes down. So behavioral activation in my model reverses those 3 things. So if you haven't got much time, just ask the patient, are they in touch with their friends? Probably no. What are they doing for play or pleasure? Probably not much. And what are they doing for exercise? And get them committing to doing something like that. When we had the trial, I was phoning up the patients, and I began to tell who was in what group. I didn't know what group they were in, because the patients just said, I just needed a push. And that's getting them back in the river of life. So it's a nice little ACT term, the river of life. You say to patients, I need to get you back in the river of life. So let's get on with it. Values, this is what's important in the long run. These are directions, not goals. So a goal is achieving a specific thing. A value would be my family's important to me, my health's important to me, money's important to me. And if you know what somebody's values are, you can then weave that into behavioral change. So I think if you're trying to get someone to quit smoking, they've got to have a big reason for it. People just won't, the pull of tobacco is so strong that they have to, it's either health or money or family or children. Very good if they've got young children. You just say, well, your child's got a cigarette in their mouth. And they go, well, that's awful. I say, well, you're the role model. They're learning from you. So, yeah. Okay, taste 2. Someone, woman in her early 30s, hadn't been feeling very good for a few months. The EMAQOL was 45, PHQ-9 was 22, so that's pretty high. This is the severe range. Her GAD was 20 out of 21. In 2022, she had the death of an uncle, an aunt, and a cousin in EMVA. And I have to say, this is not an uncommon thing to find families where they have multiple deaths in the space of a year. I think it's all to do with equity. She never had any distress issues before, and she wasn't keen on medication because remember, she's up in the very high range. So I did a work love play, the contextual history, and she had 3 out of 10 struggling to cope with pressure at work. Now, it wasn't that work was causing her problems, but with a PHQ-9 at 22, it's pretty hard to get out of bed in the morning. This lady was doing pretty well to get to work. Love as in friends, 3 out of 10. She had one friend, but wasn't in contact with them. I had a good partner, good relationship, good family, play and recreation, 2 out of 10. So that's the classic pattern again. Lovers and friends and play and recreation. So with the work thing, that was interesting. The work wasn't a cause in her case, but she did want to quit work. So this was the rest of the work love play. She did a lot of walking at work, and I had a chat to Pim about this. I somehow think recreational exercise is different from work exercise, because I think you're in charge of that. There's sometimes a social component to it. And I just think it's different from work exercise, but I don't know of any data on that. I don't think there's research on that. No, but it's an interesting point, I think, isn't it? Yeah, it is. Her sleep was poor, no drugs or alcohol, gambling wasn't an issue. Previous partner, she'd had a violent relationship for 13 years, and she stayed with him because of his children. Spiritual, nothing. She had relative infertility, 2 years of trying. Her partner has a child, and the unresolved trauma was the 3 deaths in the close relatives. So at the first visit, I recommended a behavioural activation, to contact a friend for lunch, and she said that would be 8 out of 10. Going for walks, 7 out of 10, and go on a date with a partner. It's often something I suggest to people because they will have stopped going on dates almost certainly because of her distress. So I thought we'd done pretty well at that visit, and something would happen. 1 week later, hadn't done her tasks, and actually her EMA-QOL was lower. Remember, it was 45, and her PHQ-9 was still 22. Her GAD was 20. I did encourage her to do tasks, but she decided she'd quit on her job because she could go back to it, and money wasn't an issue for her in the short term. Her sleep wasn't so good, so I gave her quetiapine, half a 25 milligram. I didn't really want to get her on benzodiazepines, and that she found quite helpful. We discussed antidepressants again, but she said, let's wait, or we decided to wait and see how she did with stopping the job, whether that would make her life easier. I'm always reluctant to have people quit jobs, particularly when they don't have another one to go to, because I've seen so many people, they walk out, slam the door, and then they can't find another job. Yeah. And so that's an issue. Never make important decisions when you don't feel well. Good point. That's never a good point. Yeah. So I would have been okay giving her maybe a week off work to see if that helped, but she was pretty gung-ho on quitting the job. 3 weeks later, she'd done the task on this occasion. The EMA-QOL was now 40. She was sleeping better with quetiapine, but her PHQ was 21. Remember, it was 22 before, not really shifted. GAD was 18. I encouraged her to keep exercising. I did suggest she do the online CBT, Just a Thought. I didn't prescribe it, but I'm trying to get her email address so I can prescribe it, but I haven't been able to catch up with her. She's not attended. So this is just a summary of her visit. So this is week 1, week 2, week 5. And so you can see the PHQ-9 is not moving. The GAD is not moving. And really the EMA-QOL still staying well below 60. So we had a discussion about medication, and I gave her sertraline, which won't be an issue if she gets pregnant, 50 milligrams for 2 weeks, and then 100 milligrams thereafter. This was the dosing regime and the PANDA trial. We're going to talk a little bit about the PANDA trial because they had a massive placebo response. So I did suggest the online CBT, but and it's known in Australia as this way up. If you so it's been studied in Australia, it's been made fit for New Zealand. By the way, if you prescribe it, if you go in and as a clinician email a link to your patient, the patient is twice as likely to do it. So we just had a lunch with Anna Elders the other day, and she told us about that. So that was good. So it's an online CBT. So how would we do as GPs, would we do the guided stuff? How involved would we be if we're going to do that? Because if we set them off to do it on their own, that's going to have a small benefit. But if we guide with them, so how much sort of time would we have to spend with them?
I don't think there are many GPs who do the coaching themselves for internet interventions. It's usually nurses or a psychologist who do the coaching.
Okay.
And then give the feedback to the primary care physician.
So it'd be a good thing to get our nurses doing, perhaps.
I think nurses are very well in doing this.
Yep. Yeah. And I think the nurses would love doing it too. So this is the prescribing for just a thought. We've made up a name, John Smith. So this is how you prescribe it. And you have a choice of these options: generalized anxiety, depression, mixed depression and anxiety, staying on track during COVID. And there's New Zealand sign language options, social anxiety and obsessive compulsive disorder. And I think they're working on a PTSD one. I think that's what she said. Yeah. She might be online at the moment, so she might like to put a comment in the Q&A there.
Yeah, because this woman, she had this abusive relationship before. She didn't want to go away because of the child of her partner, and she had 3 relatives dying in a shot. So that feels she's pretty traumatized, or she doesn't dare to stand up for herself. And so in that case, I really think this could be post-traumatic stress problems, and complicated ones, because abuse can have so much impact on how you think, what you do, how you feel, what happens, that I think it would be good to if that's the case, if there is post-traumatic stress, then I think it's better to refer to a specialist in PTSD.
Yes, I'm not making any progress with this lady, so we need to review the diagnosis. We need to review the treatment. I will do a screening test. There are screening tools to look at PTSD, so I will get that. Actually quite hard for us to get like secondary care psychiatry. We do have a psychologist who comes to our clinic, but I think the waiting list is many months.
That's a big problem.
And this is data from the PANDA trial, which was quite interesting. This was a randomized trial of patients where the GP thought they would benefit from an antidepressant. And this is what they found. So the baseline PHQ-9 was 12, and 60% of the participants had been on an antidepressant before. So there's sort of a group that's had treatment. But when I looked at it, I couldn't believe how well the placebo response was. And I showed it to Pim, and he had the same reaction. So there's like a 5% difference there, 52% in the sertraline group. This is at week 2, 47%. That's pretty big for week 2 anyway. And then 63%, 58%, so still just a 5% advantage. And then an 8% advantage here. And I remember looking at this and thinking, wow, placebo is pretty good in primary care. You know, there's not much difference. And And what was your response to that?
Well, these data are shocking that you have. I don't know how they defined remission. I think it's on the PHQ.
Yeah, less than 10.
Yeah, exactly. So that's not really remission, because that's below 5 on the PHQ.
Usually,
but still, these numbers are very high. And usually you find remission response or remission rates, because this is more a response rate, I would say, of 36, 38% in most drug trials, which is already very high. You know, but this 65%, I don't know of any other drug trial that has shown this. That can be specific for primary care, but it can also be a chance finding the specific population in the UK where it was done. So I really would like to see replication studies finding the same thing.
And you also made the comment that actually in primary care, some of these distress symptoms can be more transient
Yes.
than in secondary care, because by the time you get to
Absolutely.
secondary care, 50% have disappeared,
Exactly.
and you've had it for a longer period of time. Although these were people that the GPs did think would benefit from antidepressants.
Yeah.
So that's an unusual study in that sense. But
But also the remission rate in the treatment group is very high, much higher than what we find in normal drug trials.
it's hard to get to 73%, isn't it?
Yes.
Yeah.
Yes. Usually much lower.
Yeah. So anyway, that's the Panda trial is quite good in the sense that they used a PHQ-9. It's in a normal a reasonable, a sort of expected primary care population. Because some of you will know I was involved with the Cochrane review of antidepressants in primary care, and almost all those studies were in severe or very severe depression, which isn't the population. This is much more PHQ-9 12. The average PHQ-9 in my patients is 14 to 15. So this is right in that sort of territory. What about trying another drug if one drug, well, she hasn't had enough time on one drug, but this is from the STAR-D. And the problem is when you try the second drug, there's only the effect size drops by 50% roughly with each new drug. So you're running out of room. So if we started at 6 to 8% effect size for mild, moderate, second drug would be 4%, third drug would be 2%. So it's getting a bit.
And STAR-D is an uncontrolled trial. So these 50% in the first step, there you should actually take away 36 or 38%, which would have responded to placebo. So the actual effects of drugs are also, just like psychotherapy, pretty modest.
Okay, so let's finish. Some of you will have seen these slides before. So this is from the a poster that Pim actually sent me, so I wouldn't have had this without him, of the baseline severity on the bottom here, and this is a reduction in mood score. So that's drug and that's placebo. So a bit like the Panda trial, placebo is pretty good, drug's better, and this is the effect size. This is the NNT. This is secondary care and primary care. So when our secondary care colleagues talk about how wonderful antidepressants are, they're dealing with a group of people with big effect sizes. Ours is much smaller.
Can I say something about that? Yeah, so this is what happens in secondary care is the effects are larger than in primary care, but they're still pretty small. It's only a few points on the Hamilton. So it's not that in secondary care that the effects are suddenly, that everybody gets better. That's not the case. It's a little better than placebo.
There's only about a 2-point difference, probably a little bit less on the PHQ-9 because the PHQ has a smaller range than the Hamilton D. So this is also something that I think our secondary care colleagues, we see somebody at the first visit, they're seen, heard, and understood. We listen to them, we give them empathy, we give them hope, and visit 2, they're better. So if you drop an antidepressant on a patient at this visit in primary care and have a nice talk to them, they're going to be feeling better. But it's probably not the antidepressant, because after a few weeks, there'll be very little difference. It's probably what you do in talking to the patient. And that old thing of being seen, heard, and understood is very important for us as humans. So this is the trajectory we're dealing with in primary care. And we sort of saw that in that Panda data. This is the effect size. So the placebo rate is about 41, 42% in primary care. This is very severe depression. This is severe depression, and this is mild to moderate. This is based on a different study than the FDA data. The FDA data is not quite that understandable. And this is the numbers needed to treat. 4 down here, 11 here, 16. So when they start getting up here, you're having to treat a lot of people to get somebody better. Remember that 41% of them will get better. So roughly half of them will be better even when the NNT is 16. Okay, so we've got another case.
So maybe I can say one more thing about this. Yeah, so it's pretty clear that antidepressants also don't work that well. Same is true for psychotherapies. And the thing that when people get better, there is also this very high relapse rate. So in the Lancet Commission, we said that maybe we should consider depression also more a chronic condition instead of only an acute disorder.
So one of the things, and I've said this to you, is that in primary care, there are a lot of people who are going around on antidepressants and they're still very depressed. They don't want to stop them because they're worried they'll get worse. So what would you suggest we be doing? And in every practice, there's lots of patients. We've got lots of them. We keep repeating their SSRIs and they're clearly not working. But what would you suggest we do with those
well,
people?
People usually go on taking medications because they're afraid that when they stop, they get depressed again. And there is not real good research on how to help people with that. And so there is now in Holland a big trial on these tapering methods on how to reduce the dosages.
Yeah, Tony Kendrick in England has done a bit of stuff on
Right.
He's got a trial going there as well.
Yeah.
Yes, we're good at starting medication, not good at stopping it.
Absolutely.
Yeah. Okay, so this is a case where the diagnosis is the distraction, and if you're not careful, the treatment becomes the distraction. So this is a woman in her 30s, and she's a diabetic. I like diabetics because you can watch their HbA1cs improve over months after they get better. And she came in and said, my anxiety's getting worse. My citalopram isn't working. My immediate response to this was probably the citalopram never worked. You probably got a placebo response and your life has turned to custard, and that's what's happening. And I wasn't going to change her medication at that visit because we'd go through a whole circus of adverse events and doses and all that sort of stuff. So and this lady said, I saved her marriage at one visit, which wasn't my intention, but her PHQ-9 was 12 out of 27, but the GAD was 17 out of 21. Now that is an anxiety picture, I think. She was right. She didn't have too much mood problem, much more worry. Her work-love play was 8, 5, 5, 8, 3. Now the 5 for relationships was probably a 1 because she just started off complaining about her husband. And she was saying, well, he's not doing things around the house. And I began to think, well, maybe he's depressed and that's why she's anxious. But it turned out, and you should not do this at home with your husbands, wives, or teenagers. Ask if they'll do a task, and if they don't do it, go and do it for them, because you've just signaled that it's your job, not theirs. And that's what's happening with him. She'd suggest he do something, he would do it not to her level of satisfaction, so she would go and do it. And after a while, he gave up doing things, which is, a perfectly normal response to that sort of behavior, really, straight operant learning. But I said interestingly, she loved her job, and she had 50 days vacation owed, which I think is a very bad sign in somebody who loves their job. So I suggested she go away for a weekend with her husband. They went away, and she came back at the next visit and said, we talked about what I was worried about, and I slept perfectly on Saturday night. And so I said to her, do you think the citalopram kicked in on Saturday night? Such was her faith in medication. She was a bit unable to connect the fact she'd talked to her husband and that. Okay. So she said, I saved her marriage one visit. Now, the funny thing about this consultation was our practice nurse came in and showed her how to prick her finger for blood glucose. And I thought, well, I'm going to get her blood glucoses every day for the next 3 months on an email. But actually, it was really good for her because when she got stressed, her glucose went up. So classic 1970s behavior modification, measure the blood pressure, relax, and see how you do. So actually, it became a very good measure of her stress. And this is her HbA1c. So you can see she's really only just become diabetic at the visit. And after the visit, it dropped down to 44 and it stayed down here a long while. Of course, the only problem with HbA1c is her pancreas is slowly aging and conking out. So if you watch this for a long time, and her diabetes got worse some years later, and again, it came down with an intervention, and then she got bariatric surgery, and it came down massively. Okay, so was the citalopram working at all? Do we have any mechanism why citalopram would stop working, or do you think my my instinct was okay there.
I think your instinct was okay. I don't think it stops working.
Yeah,
we don't know very much on how antidepressants work.
There's only one paper I can find of so-called tachyphylaxis, antidepressant stopping working. So there isn't much literature on it. So WTF stands for what's the function of her anxiety? And the what's the function of her anxiety? Now, we don't often do this in general practice. It's more a psychology routine, but it's really good to think, what's driving this? And for her, it's a second marriage and she's not talking with her husband. So deep down, she's scared. If she talks to him about these important issues to her, they're going to have a big fight and he's going to be out the door, would be my guess if I explored it. I didn't explore that, but I think that's the function of her anxiety. So this is just a great slide about depression, shared symptoms, and anxiety. And I just wonder if you could just maybe make some comment about this, what the distinctions are, how does depression differ from anxiety? What's going on?
I think it's pretty clear that depression and anxiety are one cluster of mental health problems. If you look at the diagnosis according to the DSM or the ICD, you see that depression and anxiety are often comorbid, but that's only on a diagnosis level. If you look at subthreshold symptoms, then almost everybody with depression is also anxious, and the other way around, with at least some symptoms. So there is a lot of overlap between the two, especially for generalized anxiety disorder. If there are other anxiety disorders, panic disorder, social anxiety disorder, and these are somewhat different than generalized anxiety because they have an element of phobic disorders. And phobic disorders, the best treatment for that is exposure. So graded exposure to the thing you're so very worried about. You're so very scared of. And then you make a hierarchy of that when you're afraid of elevators, you first go and watch the elevator, and then you wait until your anxiety goes down, and then you stand in front of it, and then wait until your anxiety goes down, and then you open the doors but don't get in, etc., etc. So it's graded. You go to your feared thing in steps, and wait at each step until your anxiety goes down. And in the beginning, a patient thinks that won't happen, but it always happens. And that means that simple phobias like anxiety for heights or for animals or whatever, they can be treated in one afternoon, very simply with exposure. For more complicated phobias, that can take a little longer. Social phobia is a little more difficult to treat because it always involves other people. And that's also part of the anxiety cluster, so to say, but they really need different treatments. But for depression and generalized anxiety, I'm not sure whether they're really different things.
I'll put a little comment there, going crazy, because I find people with anxiety feel like they're going crazy. I don't get my depressed patients saying that in the same way,
No.
Which is nice, because you can say, well, you're not. The fact you're worried about it means you're not.
Yeah,
So,
yeah.
that's quite good.
Yeah.
So this is from the MAGPIE study, the overlap of anxiety with depression and the importance of substance use. It's very hard to get people better because I think the neural pathways for substances are much greater than our talk therapy.
It interferes with everything.
Yep.
Substance use.
Yeah. Okay, so here's a little advertisement for our symposium. We've got Judson Brewer from Brown University who'll be talking to us online on the Sunday. He's got a curiosity intervention with an NNT of 1.6 for anxiety called Unwinding Anxiety. It's an app. It's quite expensive. It's about $11 a week or $7 a week. But he gets patients, instead of doing anxiety, he gets them to do curiosity. And that activates different parts of the brain. I asked him about this and he thought that's a pretty good NNT for an unguided intervention. So we've got a question for Professor Brown when so that's the Goodfellow Symposium, March 26th, if you want to sign up for that. And I think we'll go through to the questions now.
Sure. Thank you both for your presentations. Some questions have come through. So someone's asked, should the diagnosis and treatment of perinatal depression be considered separately to general depression or distress?
Yeah, there's a debate about that. Perinatal depression is the same depression as normal depression, but then in the perinatal phase. In terms of treatment, psychological treatments work just as well in the perinatal phase. So I'm not sure, and it's not clear whether it's really something different than whether it's really associated with that period women go through. So it's not clear. For treatments, it doesn't matter. So psychological treatments work just as well.
Thank you. Where can people find more information about the EMA-QoL score?
It was a gym a few months ago, so they could go that if they're having trouble. So it's been validated twice now. And it validates even better against PHQ-9 asks about the last 2 weeks. We used a depression questionnaire, which asks about people today. The likelihood ratio was 25, which is absolutely massive in healthcare. I realize people aren't familiar with likelihood ratios, but very highly correlated. When you get a low score, very specific, not very sensitive, because you can still have anxiety if you've got a score above 60, but for low mood, it's very specific. You get a 10, you've got a very flat patient.
Now, you mentioned, I think, Pim, the correlation between smoking and depression. Is it the same for vaping?
Yeah, I don't know that. It's vaping is pretty new, so I'm afraid I don't know the answer to that. Sorry about that.
Because it could be a final common pathway, couldn't it?
I think so.
It'll be a correlate rather than a.
I think so, but I don't know the research.
That'd be a good question,
Good
actually.
question. Yeah,
we must ask the NIHI people. Thank you. That's a good one.
Any suggestions for treating drug misuse in people with anxiety and depression symptoms?
Yeah, so we did. We just published a paper about that, about the effects of psychological treatments of depression and substance use problems. And actually, the results were pretty disappointing. So if people have depression and substance use problems, the effects are very small. If you, regardless of whether you focus on the substance use problem or on depression. And the effects were just significant effect sizes of 0.2, 0.25. And so that's really, really a very difficult target group. Yeah. And it's not very clear what we should do. I mean, the treatments work a little for some people. So I certainly would recommend to go into treatments, but the effects are really very, very small.
Thank you. And some patients are coming in with depressive anxiety symptoms, plus or minus substance use, and then throwing in the questions, I think I've got ADHD. So someone's wondering what you do in that situation, because there's really almost no capacity for people to be seen for ADHD in the public system here. Do you have any strategies for primary healthcare practitioners?
Oh, I mean, that's really, I mean, ADHD is also very prevalent in adults. So it's not just something of children or adolescents. So it's really a problem. And I don't know the New Zealand system very well, but if somebody thinks that she or he has ADHD, I think that requires a good diagnostic interview and see which treatment options are available. It needs completely different. I mean, Ritalin can be used also in adults. There are behavioral activations, behavioral interventions, but there's hardly any research on psychological treatments of adult ADHD. So I think this is really something for specialists also.
It's very hard here because you can't get it. The public secondary care system won't see adults, so people have to go privately, so my patients can't afford it. I have a system, I have a friendly psychiatrist, and I do the adult ADHD form and ask a few questions about how things were at school, and then I talk to the psychiatrist about it, and he usually okays a trial of Ritalin. The thing with Ritalin, if it's going to work, it'll work pretty well straight away. People know very quickly. And I've got a couple of patients who were thought to have anxiety, and actually they're off all antidepressants and they're actually on Ritalin, and they're doing very well, particularly when there's occupational issues. Some of these people, particularly the women, just lose job after job after job, and nobody picks it up. They get on Ritalin and they get satisfactorily employed because they can concentrate. So just remember, the women and the men are quite different. The men show up because at school they're wrecking the joint. The women are just dreaming away. So there's quite a difference there, but it's not making deadlines. And so so in New Zealand, you sort of need a friendly psychiatrist, maybe someone you went to med school with, and play upon their good nature, because they realise the system is hopeless. I think we should have a system here whereby we could do it if we have the right questionnaires. I mean, sometimes it's so obvious they're all over on this side. The odd patient, you're not sure, but then a trial of treatment can be quite useful. And sometimes the treatment doesn't work. I mean, there's a placebo component, of course, but so that's my solution to the problem. But that's just because the system is broken, really.
All right, we'll wrap up with the last question. It's quite a specific one about one of your cases. The one you gave quetiapine short-term for sleep. Is that associated with weight gain at all?
I don't know. The trouble with quetiapine, there's not much known about it. I was trying to get Barry Gribben to look at what effect it has on lipids, because it's a pretty weak antipsychotic. You know, you put somebody on olanzapine and you've got a metabolic mess. You put somebody on quetiapine and it hardly changes thing at all.
Okay, great. All right. Well, we're coming up to closing time. So thank you again, Pim and Bruce, for taking your time to present this evening. And thank you everyone for joining us tonight. So have a lovely night, everyone, and stay safe.